morning, afternoon, evening, depending on the part of the world you're joining us. And thank you for coming on board for this webinar as part of the activity, the webinar series to mark the Global Health Week. I'm so delighted that we all can make it to this webinar. And just before we start, if you can see the screen, just to show us the agenda for this webinar. So within the next 3 minutes, I'll be through with this opening remarks, and then I will introduce the panelists that we have, and then we take the goodwill message from the National Coordinator, Neglected Tropical Disease Program, Federal Ministry of Health, Nigeria. And then we take the first presentation just as display the overview of Nigeria NTD Master Plan 2023 to 2027, where we get to listen especially to the target and milestones set by the government of Nigeria towards implementing essential care package on mental health and anti-stigma for patients with morbidity associated with NTD. And then we go to the meat of this webinar, what exactly are the components of care package, and that will be taken by Dr. Tunde Ojo, the National Coordinator for the Nigeria National Mental Health Program. Then we also look at how to actually integrate. Yes, you will have listened to a presentation on NTD, as well as essential care package for mental health. And we have Professor Taiwo Obindo from University of Jos, Nigeria, to do justice to say how to, integrate. How do we integrate the co-implementation of mental health care as it's related to NTD? And then we move on to Rogers, our friends from Liberia. They have been implementing essential care package with NTD in focus since 2016, and we will learn from their experience so that we bring practical lessons as to how to go about implementing these essential care package. And then we also take a few activities. Some of our partners in Nigeria who have been supporting NTD program have actually initiated some beautiful programs that we all can learn from, and that will also be presented to the House, so that at the end of this webinar, the goal is very simple. I know it's a bit of a new concept when it comes to management of NTD patient, but we have one clear goal in mind, is to empower the audience with as much, as many information that we will need to implement this. So if you are NTD program managers at the national level, at the state, at the local government, this information within the course of this webinar will be useful in order to scale the implementation of this essential care package on mental health and an anti-stigma campaign for people affected with NTD. So once again, welcome, and I'm very sure that we'll get value for our time this moment. So we've put together amazing speakers, just like I mentioned, who would do justice to the subject matter today. But just before we take our first presentation, let me allow us to hear a goodwill message from the National Coordinator, Neglected Tropical Disease Program in Nigeria. And after his goodwill message, I'll be back to take the first presentation, and we'll take it one after the other. And so it's my pleasure to welcome Mr. Adebayo Peters, representing the National Coordinator for Neglected Tropical Disease Program in Nigeria. Sir, if you can hear me, you have the floor for your goodwill message. Thank you.
Yeah. Can you hear me? Can you hear me?
Yes, from my hand.
Can you hear me?
Yes, please.
Okay.
Please go ahead.
Yes. I hear you.
Yeah. Good afternoon, good morning, good evening, wherever you are connecting from. I'm Adebayo Peters, a program manager with NTD program and a director in the neglected tropical diseases. I'm standing in for the national coordinator, Mr. Fatai Oyedino, who is currently not available. I want to sincerely welcome every one of us to this webinar meeting, and also want to thank you for giving us this opportunity for participating in this 1 week program that is being sponsored by your organization. And just like Gabriel said, we do hope that this time you have given to us will definitely have, both of us will have a value for the time that you have allotted to us. And on behalf of the Minister for Health, I want to tell you thank you for this opportunity. I just want to give you a brief goodwill message on behalf of the Federal Ministry of Health. As you all know, according to the World Health Organization, neglected tropical diseases.
If you don't mind, sorry for interrupting you. Can you put on your camera, please? So that we can, if you're comfortable with it. Yeah, thank you, sir.
Okay. Okay. Yeah. Is that okay? Can I continue?
Yes, please. Yes, yes.
Okay. Yeah. According to World Health Organization, neglected tropical diseases contribute nearly 1% of the global burden of diseases globally, and more than 1.7 billion people globally require treatment for at least one NTD every year. An estimated 100 million Nigerians are at risk of at least one NTD. Global and national implementation of the neglected tropical disease program have largely been preventive and curative, focusing on addressing physical symptoms through mass administration of medicines for more than a decade. Despite this, very little attention has been paid to NTD morbidity experience, which experience significant distress and social exclusion, which has an impact on their participation in society, including their civil and political rights and livelihood, all of which are recognized determinants of mental illness. The resulting emotional consequences of living with an NTD can lead to psychiatric comorbidities like depression, anxiety, substance abuse, and suicide, exacerbating the physical effect of this condition. The newly launched Nigeria NTD Master Plan 2023 to 2027 set a clear goal and target in line with the World Health Organization NTD Roadmap 2021 to 2030 to better address the mental health and stigma associated with neglected tropical diseases. As part of the webinar series to mark the Global Health Week, the Federal Ministry of Health have put these amazing speakers together to engage our audience on how to implement essential care package for mental health and anti-stigma campaign for people with morbidity associated with neglected tropical disease. I do hope you will find this webinar informative and empowering. Thank you very much. And I want to thank you for your attention. Thank you, and over.
All right. Thank you so much, sir, for that beautiful goodwill message. And that in a bit sort of provided a background as to why this webinar is very important. And without wasting much of our time, we'll move next to the first presentation, which is about the NTD program in Nigeria, and then a bit of the master plan content, and that will form the background for today's presentation. So I'll just take that presentation. I'm the one taking that presentation. I'll just pull it up right away. Okay, so I'm taking the overview of NTD in Nigeria, and again, also talk about the NTD master plan briefly before we look at the essential care package from the mental health component. So what are NTD? Neglected tropical diseases, a group of 20 disease conditions that are common in tropical or subtropical regions and are closely associated with poverty, poor sanitation, lack of safe water resources, substandard housing conditions, and deficit healthcare access. The diseases are called neglected because they tend to affect the world's poorest and receive less attention than other diseases. So basically, the NTDs are grouped into two based on how they are managed. One group, therapy NTD, and these are very common in Nigeria, and as well require treatment through mass administration of medicine. So these are a group of NTDs that we manage by distributing medicine through to everyone living in endemic environment. An example of disease is onchocerciasis, lymphatic filariasis, schistosomiasis, soil-transmitted helminth, and trachoma. how widely spread are these NTD diseases. This was the outcome of our mapping, which was done around 2010, 2013. And when we started, as you can see, for trachoma, about 122 LGAs are endemic, putting over 26 million people at risk of trachoma. For onco at the onset, about 481 LGAs are endemic. Besides, we have 774 LGAs in Nigeria, and putting at risk about 51.4 million people. For schistosomiasis at the onset, about 582 endemic LGAs, putting at risk 41 million school-age children. For soil-transmitted HELMI, about 429 endemic LGAs out of 774 LGAs in Nigeria, putting 44 million population at risk. And then we have the lymphatic filariasis with 538 endemic LGAs at the onset, putting at risk 119 million Nigerians at risk. Of course, we've made progress over the years, but just this is how widely spread these diseases were at the initial stage of this program. Apart from the 5 NTDs that we manage through mass administration of medicine, we also have other group of NTDs that we call case management NTD. Some of them are also called, for us in Nigeria, you will see a lot of skin NTDs also classify as case management NTD. And there we have snakebite, envenomy, rabies, borreliosa, leprosy, yaws, and leishmaniasis, scabies, and mycetoma, human Africa trypanosomiasis, and as well as guinea worm disease, which we have eliminated in 2013. Just to create a link, most of these NTD have morbidity associated with it, especially the case management NTD. And I just decided to pick one, looking at borreliosa. You can see that it affects both an adult and even children less than 15 years. I mean, nearly the 50% of the BU cases we have in Nigeria affect children less than 15 years. And from the picture you can see, you see that it leaves people with morbidity. And how do we manage beyond just treating the wound? There is something more to do in order to, get them back into society. And that's why we observe that we've not been able to, we've not been really putting in an holistic care as it relates to NTD patient, because we always focus on treating symptoms and administering pill to them. But we also, moving forward, are now interested in assessing their mental well-being. So when they show up with a permanent contracture of the limb, there are things that are also going on in their mind. Having administered the P to them, can we also assess their psychological state and ensure that we're giving an holistic care as it relates to their well-being? So this slide is just to establish that, yes, we have NTDs with associated morbidity. And one example is this borreliosa. Now, as a country, we have one goal, and it is to have a country free of NTD diseases. Our goal is to have a country free of neglected tropical diseases. And as well, what we want to achieve is to control, eliminate, and eradicate NTDs through reduction of morbidity. If we can detect the cases on time, we can reduce the morbidity as well as mortality rate to the barest minimum, and also ensure that government at all levels take full responsibility for NTD elimination in Nigeria. And this beautiful goal has been documented in what we call the Nigeria Master Plan for NTD. This plan was launched this year, January, as one of the activities to commemorate the World NTD Day. And what I put below is the link. So when you check the, if you click the link below, you can have access to it. So it's on the Nigeria Ministry of Health website, and we all can have access to it. Now, why this plan? It's very simple. Master plan is a comprehensive multi-year plan for the control of all NTDs endemic in the country. And it helped the government to effectively plan and implement sustainable NTD programs. It also provides program goals, objective, year strategy based on extensive situation analysis, and addresses all components of NTD programs relevant to the country. Of course, it enhances synergies among various NTD initiatives, provide the basis for integrated NTD project plan, and include costing and financing requirement for effective NTD program performance, and form the basis for harmonized implementation and performance monitoring of all NTD intervention in the country. So the NTD, the Nigeria NTD Master Plan, of course, has 4 chapters. The first one is the situation analysis, the strategic agenda, operational framework, and estimated budget. And it sets ambitious goals towards control and elimination of 13 endemic NTDs in Nigeria, including onco, lymphatic filariasis, schistosomiasis, soil-transmitted helminth, trachoma, snake bite, envenoming, yaws, leishmaniasis, rabies, human Africa trypanosomiasis, leprosy, borreliosis, as well as comorbidity of NTD with mental health, while maintaining surveillance for guinea worm disease. The master plan also adopts best framework. That means in order to really eliminate NTD, we have to put all these components, pay attention to all these components. When we talk about behavioral change, it's one of the components, including the use of, clean facilities, and also have access to clean water. People should know the consequence of going or making use of or living in a poor hygiene as it affects their health. We also put in place the heat. There is the environmental manipulation. We can also control the vector, that serve as an intermediate between the host in order to manage the NTD disease. One of the approaches is also social inclusion, and which is the core subject of this webinar, which is addressing stigma and discrimination. In addition to treatment and care, including the mass administration of medicine and morbidity management that we are all used to. So just more like an overview of that plan. Like I said, it has 4 strategic pillars, 29 priority areas, and 147 strategic activity. it is expected that with investment of 8,641,515,363 naira, which is equivalent of $18 million. If we have this investment for 5 years, we will see a lot of improvement in achieving some of the goals that we've set for ourselves in that plan. Just like I said, that there are about 29 priority areas and 147 strategic activity. Here is to show us how mental health, this is the first time that we really pay attention to the mental health component of NTD patient, and you can see it in pillar 1.4. So I want to encourage every one of us, after the webinar, I'll leave the link, kindly go to the Federal Ministry of Health and Nigeria website to have a copy of this master plan so that you can digest the content properly. So for pillar 1, we have one of our strategic priority is to strengthen access to people-centered mental health care for people with skin NTD and physical deformities in Nigeria. And the way to go about it is to improve access to mental health support and treatment, improve access to livelihood opportunities for people affected by skin NTD, improve public awareness to reduce stigma on mental health condition in skin NTD and physical deformity, as well as screen or NTD patient for mental health condition at diagnosis and why on treatment. So these are some of the strategic activities that we put in the master plan. Also, one of our key priorities also to procure psychotropic medicine to manage common mental health condition coexisting in skin and physical deformity caused by NTD. We also, one of the approach to reduce stigma and discrimination associated with NTD. All these activities are lifted from the Nigeria NTD master plan. And so this dissemination is just to steer your interest to, download that document, read it, and so that you also, as a worthy partner, can know how to contribute to the achievement of this goal. So under the reduction of stigma and discrimination associated with NTD morbidity, we want to encourage support group creation for mental health enhancing activity. We also want to increase public awareness, just like we're doing, on comorbidity of mental health disorder and suicidal tendencies in persons with NTD, as well as increase inclusion of persons with NTD in community activities to reduce stigmatization. All of these are well documented in the plan to eliminate, towards elimination and control of NTDs in Nigeria. And lastly, to also improve governance and coordination for implementation of mental health and NTD. Of course, we know that this mental health program is a standalone division in the Department of Public Health, Federal Ministry of Health. Also, we have a mental health, a national mental health program, which is also a standalone program under the Public Health Department of the Federal Ministry of Health. And in a way to work together, we have to improve coordination, within the department, and by extension, even as we relate to other external stakeholders. So one of the strategies to strengthen this integration of mental health and NTD care is to have in place policy to ensure collaboration between the mental health services and NTD program in primary health care facility and community, conduct together advocacy and sensitization workshop on mental health and NTDs to key stakeholders, just like we're doing, sensitize people living with NTDs in an endemic area about the associated risk of developing mental conditions and psychosocial distress, disseminate information on availability of mental health services to people living in NTD endemic area, as well as involve primary health care doctors, mental health nurses, community health workers on mental health, and NTD review meetings, monitoring, training, and biannual meetings. So all of these are things we put together in order to strengthen governance and improve coordination for the co-implementation. So just more of a performance indicator there. We want to ensure that mental health is integrated into NTD program implementation at all levels. That's why I want to believe most of the people joining us, especially in Nigeria, are program managers, those who will take the message home and see how to put in place an implementation plan to ensure mental health is properly integrated into NTD program implementation, not just at the national level, but also at the state LGA, even facility and down to community level. At the end, we also want to see that at least percentage of population who demonstrated knowledge and awareness of mental health associated with NTD, it's at least 50% within the next 3 years. And then the number of NTD staff at all level trained on MHGAP, at least we have 2,000, health workers who have been trained, who are actively, involved in managing NTD patients, who have also been trained on MHGAP. We will hear about MHGAP in the subsequent presentation in this webinar. And all of these are just what we put in place in order to achieve the set goal for our program. Just between the time that we launched the master plan, which is January this year, we've also there are progress that we've made in implementing this plan. The first thing we did is to develop a training manual. So we put our case management entity, there are about 10 of them. So we develop an integrated manual, including how to screen for mental health for NTD patients with morbidity, as well as strong referral pathways. And then we've also harmonized our case management reporting tools and referral pathways. So initially, implementation of program is parallel, but between January and now, we've called stakeholders together and we've been able to come up with reporting tools that we can use to track these 10 case management entity and also strengthen the referral system as related to their care. And then we've been able to also come up with indicators to track the progress, and which will be reporting both at the national and at the regional level, and also secure funding to really strengthen this process. We sincerely want to appreciate Hannesvad Foundation, for this special intervention, as well as American Leprosy Mission, especially towards ensuring that this project, in terms of mental health and NTD integration, is strengthened. So we really, really appreciate the progress we've been able to make so far. This is just to give the structure of how we work, right from the Honorable Minister to the Permanent Secretary, and then we have the Director of Public Health, And we have the national NTD program being headed by the national coordinator. We have our task force, which is disease specific, and also an advisory group called the National Steering Committee that oversee and advise the government to ensure that we achieve our set goal. And our amiable NGDO partner, these are a group of NGOs that are supporting the NTD work in Nigeria. And then we have the monitoring and evaluation units, the ADME, the NTD WASH unit, which was newly created, and also the advocacy, communication, and supply chain, advocacy, communication, and social mobilization unit, which was also newly created. So this is just to show that we have a formidable structure from the national down to the zone. You can see the zonal coordinator down to the state, LGA, frontline facility, and community. And our goal is to strengthen this structure in order to deliver co-implementation of mental health, well-being, and anti-stigma campaign as it relates to NTD diseases. The work that we're doing in the country, we're not really, we wouldn't have made any progress if not for these numerous partners that have been supporting the NTD program in Nigeria. And we sincerely want to appreciate all of them for their support towards NTD elimination in Nigeria so far. Thank you for listening. And I think the floor is now open for question and comment. Thank you so much. So we have just 5 minutes to take a question or comments. In the absence of none, we can now go on to the next presentation on the agenda. All right, I'm trying to say we have 5 minutes to take a question on this presentation before we continue. Okay, like I said, I'll put the link on how to download the master plan on the chat box. So please feel free to download the plan and get acquainted with the content of this plan. So without wasting time, we'll move to the next presentation, which is about components. So it's now to get to know what are the components of essential care package for mental health and anti-stigma. And this presentation will be taken by the national coordinator, for National Mental Health Program, Federal Ministry of Health, in person of Dr. Tunde Ojo. Dr. Tunde Ojo, if you can hear me, please, you have the floor. Thank you.
Yeah, good day, everyone. Thank you for having me and to be part of this both national and global discourse on integrating mental health into NTD care. I want to, and I'll be speaking on uh, yeah, the essential care package, the component, and the consideration. So, okay, just a moment. Okay, so have you enabled me to share? Okay. Okay, can you see my slide?
No, it has not come. Yes, it is up now.
It's up now, okay.
Yes, it's up now.
Slideshow. Okay, yeah. Okay, so I'll be speaking to the essential care package on mental health and anti-stigma in the management of NTDs, and then the component and the considerations that what inform it. And I'll be speaking on this outline. I know, so there have been a background information on the burden of NTDs, maybe just a quick skip through it, and then the double burden and neglect of both NTD and mental health, that these two conditions on their own, and from the name, neglected tropical diseases, they have a lot of intersect. And I would say that NTD, even though it's neglected, it has gotten a lot of attention. Mental health on its own has been neglected greatly globally before now, and there is increasing attention into mental health. It's fast becoming a public health priority, and both NTD and mental health are conditions of public health importance. And so neglected individually, and then now people that have NTD, if we are talking of mental health, even in the general population, that it is neglected. Now to talk about NTD, it's not something that was really of on the front burner before now, that the burden for NTD is so massive, and then nobody until recently was actually having a second look that is there something beyond beyond what we are doing that we should be doing now. And I'm just going to talk quickly on what informed this, the global response, and then how the essential care package for this integration came about, and then what are the components and the considerations. So just as it been mentioned, that there are over 1 billion people that suffers from at least one neglected tropical disease globally. And we know that there are people that have 2, 3, thereabouts. So more than 1 billion people. And of course, at least more than 40% of this global burden of NTD are found in the Saharan Africa. And of course, Nigeria as big brothers, we are big in everything. And so whether on the problem side or on the positive side, whatever, Nigeria will always have to take a big chunk of it. And so among all the African nations, Nigeria is also big brother in NTD, having the largest burden of NTD in Africa. So, and of course, the comorbidity of mental illnesses has been demonstrated among people living with NTD, leading to additional but unrecognized disability. And there are quite a lot of intersect, just like I've mentioned earlier, that if we talk about intersection between poverty, economic factor, and diseases. Socioeconomic factors play a very big role in as risk factors and protective factor for mental health. And the same thing also for NTD. We'll find out they call it the disease of poverty. And so around here also, there is that convergence between NTD and mental health. And then one wonders why it has taken this long for us or for stakeholders globally to begin to see the intersect, the commonality between these two, and that if you address one without the other, then it may just be like it's just half of things that you are taking care of. So the truth is, these people, we talk about disabilities, and if you talk about disability that is attributable to NTD, I think there are quite a lot of work that have been done in that area. But so some of these are physical disability, but there are quite a lot of disabilities that are invisible. And of course, mental health and psychosocial disabilities are part of this. And so it's one of the things that has made it not to be recognized before now. And so consequently, they are beyond the physical condition that they have, the neglect of their mental health, how they are doing their mental well-being has been there for a long time. And the truth also is that quite a lot of them have this condition because of the chronicity that is associated with this condition, and because of the stigma and discrimination that is associated with them. Stigma, discrimination, all these play a very, very big role as barriers to access, not just to treatment, but also access to every other thing in the community, social amenities, job, housing. And so just picture it. Mental health, when people talk about mental health, the thing that comes to their head is mental disorders. And so what people think about is discrimination, stigma. Nobody was, not so many people were talking about mental well-being. And so mental health is beyond mental disorder. That's just the tip of the iceberg. And so you have people with mental health condition not being able to access care, not being able to access social amenities. And so they're excluded. People with NTD2, they are excluded. Structural discrimination from what they should ordinarily have access to. Now, join those discrimination and stigma, two of them together. That brings about what we talk about, the concept of the double neglect. So this has always been, but increasingly in recent time, there were talks globally that, oh, what do we need to do about this? And just like I've said earlier, that significant progress has been made in the area of TB. NTD, talked about mass drug administration. Quite a lot of funding has gone into NTD, management of NTD, and of course, it's still far from what is needed. But despite the progress that has been made, I think then the discussion just started coming up that there is an unmet need, and that is in the area of mental health and anti-stigma intervention among this group of people. And so, when people start sitting down to discuss what are our priorities, what should we be doing, the truth is when we start taking something as a priority, then we start seeing solutions coming up. And so globally, stakeholders started saying mental health of these people is something we should consider. And of course, when it came to the front border, then ideas start coming up. And then, of course, so some of the things that has happened in that area are what you can see on the slide, So, what could we do? So WHO came up with the NTD roadmap 2021 to 2030. And then in that, of course, in that roadmap, what should be done for NTD within this decade? And following up, riding on that roadmap, WHO did also develop a guide on mental health and neglected tropical diseases. And of course, so among others, when WHO says, oh, we want to go this way, then everybody will want to go that direction too. And of course, the International Federation of Anti-Leprosy Association and Neglected Tropical Disease Network, very big, I think the most biggest network for NGOs working in this area. And so also develop guide on stigma and well-being, So, and of course, it's just like started up there, then one thing leading to the other. And then it just said, okay, we've had these guidelines, we have this document. Can we just develop an essential care package that if care are going to be, if we are talking about mental health and anti-stigma interventions, mental health, mental well-being, and anti-stigma interventions for people with NTD, if you are talking of care package, what should people be doing? Where should they do it? How should they do it? And so that is what informed the essential care package. And of course, it's just two things that are involved in this, two major components, well-being and mental health, and then stigma reduction. And so I want us for people that are on the field that this is very novel and that we are going to scale up at national level, and now that we've integrated mental health into NTD, and as Gabriel has mentioned earlier in the master plan. And so I know going forward, you can only revise and improve on what we have there. And so it means the care, the mental health, attending to the mental health needs of people with NTD has come to stay in Nigeria as a country. So it's not just about looking out for mental health conditions in these people. Of course, commonest thing among them will be depression, anxiety, and studies have shown, of course, high suicidal behavior rate among them. So, but the thing is, as healthcare workers or as policymakers, when we are talking about mental health in people with NTD, it's not going to be looking out just for conditions, whether people have anxiety or not. But what can we do, mental health promotion? What can we do to prevent? What are the risk factors that we can mitigate? So that is the component of the well-being. Because mental health is we being in a state of mind that we are able to cope with normal stresses of life, we are able to achieve our potentials and able to contribute meaningfully to our society or to our community. And so in whatever we want to do at national or subnational level, this is the orientation. What can we do from promotional perspective? When an healthcare worker at the primary healthcare level, community worker is doing something, is having interface with these people, what are the things that should be in your mind? It's not just for you to have your checklist to say, oh, I want to check for suicide, I want to check for depression or anxiety, or whether they are using substance or not. These are things that you find in the in the general population too, even though it's been found that there are higher risk of it. But the thing is, we must look at the positive side of it. What can we do with psychoeducation? So that is for mental well-being and mental health. And then the second one is stigma reduction. Stigma associated with NTD, stigma associated with even living with a mental health condition. And so even though these two intervention rubric areas are interconnected, but the truth is that they are taken care of, and you will see they enter each other, but the truth is that they are separated because the strategies that drive anti-stigma, that drives reduction of stigma evidence-based things, they are on their own. Evidence-based strategies talk about contact, talk about education, addressing some negative stereotype. So that's why it is they are differentiated, even though they are interlinked. And in a way, so even these the components are directed at different specific target groups. And what are these target groups? So these are people that live with this condition, both at individual and group level. And so you will see some of the things that you have also mentioned in the area of self-help group, community-based organization, livelihood interventions, which we have quite some of them that are going on at the country level, and that which I know some of the people that have been working in that space we speak to later on in the course of this discourse. Also, these people, they are not living in isolations. We know that the stigma is not just about them, but their family and people that are closer to them. So caregiver, family, and household intervention. So anything that we are looking at cut across this, frontline health workers, community members, and of course, without gainsaying that policymakers too. So, and also, like we said, all these interventions are across all levels of care, both from the formal system of care and community, the informal system, so that there is clear responsibility for implementation at each level. And of course, without taking so much of your time, that last year, what informed bringing this into our master plan was that WHO was trying to get stakeholders' input into this essential care package. And then we were chosen as a country to bring stakeholders together for this workshop, for them to make input, people with lived experience, people at subnational level, formal and informal sector, to say, how can we make this work? And of course, it was in that process also that we, as a country, said, okay, so this is an opportunity for us, a window of opportunity. And we were working on the master plan for NTD then. And so we waited to have the input from this workshop inform what we want to do in the master plan. And of course, I'm just speaking to the fact that there are different levels that are involved, there are different stakeholders. And this will lead me to the last point I will talk about, which is the key considerations, for developing of the essential care package. And so the key considerations are, one, integration across NTD. That is joint delivery of intervention that are common to several diseases. So you can't be saying, oh, we want to do integration of mental health into just the management of filariasis, Buruli ulcer, or so it is an opportunity that a cross-cutting thing, not an NTD specific thing. Oh, it's only for Buruli ulcer or leprosy. So it's an integrated approach that if you are doing NTD, then look at this and put it across. And of course, the second thing, the second consideration in the development of this ECP framework is mainstreaming within national health systems, improving the quality of NTD management in the context of universal health coverage. We know universal health coverage has different mode, a different approach to attaining universal health coverage. But the truth is, if we are saying, Nigeria, we've covered the 774 local government and we are doing something about NTD there. But before now, the thing is that their mental health has been neglected. And so in the spirit of universal health coverage, their mental health, increasing access to universal health coverage, we are bringing that on the table. Of course, another conversation will be like, okay, about financial protection, medication that are needed, who pays for it, and things like that. The discourse is on and on like that. And of course, integrating access to mental health care into broader health system not only improve access, but reduces stigma. And we as a country also, this is the wholesale approach that we want to use for scaling up of mental health in the country. So we are saying that to scale up mental health, we must not just be providing the services in the hospital. We must take it to the community level. We must take it to the primary healthcare level. And so the integration of NTD, mental health into NTD care in Nigeria is like the first stage of we as a country integrating mental health into primary health care, because we know that the NTD programming in the country is a very strong one that has a formidable record, being in all the 774 local government. And so I, as a national coordinator, if I have at least 2 or 3 persons in each of those local government, local government area that we have trained on how to deliver mental health services. Look at that. That is like over 2,100. That is like strengthening mental health in primary health care. If you train someone for delivery of mental health care in NTD setting, you cannot say outside that, oh, I can't do it. It's just for NTD alone. Because you have trained them, and then they can always be able to do that. And we know that stigma, the stigma about mental health condition, oh, when someone says, I'm going to hospital, that is stigmatized on its own. But when we have found out whether when you deliver mental health services closer to people in the community, it improves access to care, and it's also an anti-stigma strategy. So it not only increases access, and not only does it increase access and makes it more affordable, but it is a big evidence-based anti-stigma campaign. So coordination among stakeholders, a whole sector system-wide approach, working with other sectors within and beyond health. If you are talking about livelihood, you are talking about accommodation, you are reasonable accommodation, you are talking about raising awareness. We need the National Orientation Agency. We need the Department of Government that is responsible for economic empowerment and poverty alleviation, all that. Because if we are talking of poverty and we are looking at NTD as just an health sector thing, then it just means that we are not looking at it from all perspective. And of course, strengthening health system, improving the capacity to deliver interventions on good ground. You will agree with me, maybe Nigeria is, the NTD program I said is strong, but how strong it is, there's still room for improvement. But what I know is that the mental health system is very weak. But if you strengthen, you can't build on a weak system. And so in as much that we are looking at, okay, we want to integrate mental health into NTD, it's not going to be a silo thing. We should use it as an opportunity to strengthen the system. And so for mental health, as we are looking at it now, it talks about MH gap. So this will be an opportunity for us to build capacity. And if we build the capacity of, let's say, 2,000 or 5,000 primary healthcare workers for NTD, but the truth is those people are in the primary healthcare setting. And so we have 5,000 people that are already at the primary healthcare level and that can offer some mental health services at that point. So I think that is end of my presentation. These are some of the references. Thank you for having me.
Thank you. Thank you. Thank you so much, Dr. Ojo, for that beautiful presentation. We need intersectoral collaboration to deliver this care, ensuring that we have that capacity, at the primary health care level to deliver the common good, for not just people that are affected, with NTD, but as many people, that come into that facility can benefit from the capacity already built. Thank you so much, the National Coordinator, National Mental Health Program, in person of Dr. Ojo. So I'm looking at the time. Don't worry, just drop your question in the chat box. We'll arrange all the questions together and then take them once and for all so that we can manage our time very well. So we'll move on to the next presentation, which will be taken by Professor Bindo. It's the president of the Nigeria Psychiatric Association, and he will be taking us deeper on how to integrate. So we've learned what should be done. Then this is how we should do it. So integration of mental health services into NTD, most especially primary health care. And he will share from his wealth of experience and the project that was done recently in one of our states. Sir, if you can hear me, you have the floor. Thank you.
Well, good afternoon, everybody. I'm happy to be here, and I've listened to two major presentations, and it's obvious that people with neglected tropical disease and associated mental health conditions are in for a wonderful time as the time progresses. Thank you for the opportunity to be here. I do not take it for granted, and I appreciate everyone that is on this call. I will be talking about integrating mental health services into neglected tropical diseases, and I will give, as the Dr. Offline said, give some examples of work we have done. So that's my outline, and then I will start by looking at the background of what we have. Is estimated that the prevalence of depression or other psychological comorbidity between mental health, depression, and leprosy-affected population is between 12.5% and 76%. In Nigeria, in a work carried out by the Mind-Skin Link, a prevalence rate of depression among people affected by lymphatic filariasis was found to be 20%, and this is twice the prevalence in the general population. However, the true burden of this comorbidity has been grossly underestimated, and studies have shown that the burden of lymphatic filariasis may be around twice as high if comorbid anxiety and depressive illness are taken into consideration. At present, less is known about the mechanism leading to association between mental health, social exclusion, and neglected tropical diseases. But significantly, we know that stigma and discrimination play a huge role. Less than 10% of those with a mental health condition actually are able to access care. Why are they not accessing care? Because of stigma, because of discrimination, people's knowledge of what mental health conditions are, as well as what neglected tropical diseases, for instance. A lot of people cannot even differentiate between those who have leprosy, acute phase, and those who are no longer effective. So people shy away or run away from them. So we talk about tradition. People believe that those who have leprosy should not stay within the town and they have to be excluded. Access to care is also a major challenge. And then, of course, cost of care is quite high. In the whole of the country, what we have presently is less than 300 psychiatrists and very few trained psychiatric nurses who are subserving over 200 million Nigerians. And if you look at the location of the mental health practitioners, they're largely located in the city center. And other mental health team members are largely non-existent. If you ask them, in some states, you have occupational therapists or social health, psychiatric trained social worker. You probably will not find any there. So In Benue, despite the integration of mental health services into the primary health care a while back, we found that the structure in place to carry this out was largely non-existent also. Hence, people with neglected tropical diseases who have med conditions are either left unattended to or will have to travel to Makodi to access care, which is a long distance. Most primary healthcare providers have little or no knowledge also of mental health condition, how to manage them. As I mentioned earlier, stigma, discrimination, and social exclusion thrives in the atmosphere of ignorance. When people do not know so much about an illness, they ascribe some mystic coloration to such illnesses, and therefore, where they seek help, when they seek help, will be determined by their cultural or the knowledge that they have. Having neglected tropical disease and a mental illness is, as alluded to by Dr. Ojo, is the double jeopardy. Whereas you have a significant, largely, a great amount of problem with neglected tropical disease, and then now overlaid with mental illness, it becomes a bigger burden. With the high prevalence of depression in this group of people, I mean those with neglected tropical diseases, the level of functioning further deteriorates. And then, of course, it leads to poor compliance. Somebody who is depressed may not be interested in getting well, may probably avoid taking medication or even follow up. And then their adherence to the medication will become further poor. And of course, Dr. Afolayan mentioned the suicidality amongst them, because it's quite high. And when we talk about suicidal behavior or suicidality, we're talking about the mindset of those who have. And this is a continuum ranging from the thoughts of living, the not living, the thought of dying, the thought of the need to exit, the need to not be a body to others, to actually ideating on how and where and when to carry out the act, to the further moving down the lane, to becoming having attempts, suicidal attempts, and then eventually taking his or her life. So it's a continuum from thoughts to ideation to attempt and then the completed act. So suicidality is very high in those who have neglected tropical diseases. And then we know that social intervention for these people are not enough. Some NGOs, some CSOs are carrying out activities, but these are just a tip of the iceberg. Just a little drop. I think that's the way they describe it. A drop in the ocean. We still need more efforts and more help. Help in creating awareness about mental health condition and in the society is also increasing, because creating awareness about mental health condition, when we integrate mental health into what they call it, neglected tropical diseases, we are helping to create awareness, because when they are treated in the community, it's increasing the awareness that mental health is not a taboo, it's not a sin, it's not something that comes upon people as a result of curses or some crime that some people committed, and they see it as something that can be treated. And integrating it also locate care closer to the people and further reducing the stigma and improve social support and engender social inclusion. What do I mean? Social support. We know in Africa, in particular, we have social network a relation coming to assist and all that, and somebody has to travel a long distance to access care, those family members' support will definitely be lacking. And of course, social inclusion is the help because they are closer and the people are nearer and they can actually raise support for such persons. So likewise, access to care will be more prompt, less expensive, and will significantly reduce complication by eliminating late presentation. When people have to travel, or people who have a mental illness or neglected tropical disease have to go a distance, they had to, somebody had to accompany, one or two people have to accompany them, further increases the cost of care. Some of them have to be admitted and they have to stay there for a while, dislocating them from the community. And therefore, a lot of people will not want to go. So accessing care will not be prompt until things become severe. And then we know that the longer people are kept, the more the more poorer the outcome of such a illness. So it's also dispelled myths and beliefs surrounding neglected tropical disease and mental health condition, as I mentioned earlier. And of course, it improves livelihood of those who have it, because there will be reduced cost and they can actually function and still go for their work if treated closer to where they live. And then so they can work as well as at the same time receiving care. So I will briefly discuss neglected mind skin research project that was carried out. The focus of the work was largely intervention development through theory of change to determine exactly what people will want. We evaluated and we attend, it's meant to evaluate and promote mental health and well-being using both quantitative and qualitative research methods, and then treatment of mental health conditions that are associated with neglected tropical diseases. What are the research questions that we had? We asked, the primary question was, what is the feasibility and acceptability of implementation of a model of integrated mental health care based on the WHO intervention guide for NTDs and mental health? How well will the people accept this intervention? We know that mental health has or was meant to have been integrated into primary health care, but we're now using the neglected tropical diseases as a microcosm of the primary health care, and then looking at how well people will accept it. And secondly, what are the express priorities of service users who have NTDs in relation to their quality of life and well-being. Two local government areas in Benue State were purposely chosen, and these are Boko and Konshisha. The reality we had on ground was the fact that knowledge gap about mental health conditions was quite poor. Access road, even to where they could access care in Makodi, was far, and the road was actually fairly poor. The cohorts, those who have or who had mental health conditions along with the neglected tropical disease are largely poor, and they had to be assisted to come over to receive care. And then the support groups, even though they were not well supported. These are the two areas, the Boko and then the Konshisha in the Benue. We noticed also that the distance is quite long from the city center, and the access road, as I mentioned earlier, is quite poor. Non-existence of mental health services in the two local government earmarked for the research. Most of the people living with leprosy and lymphatic filariasis have left the community where they used to stay following discontinuation of the subsidized care by the NKST church that used to house them. So people had left the community, and then we had to make use of their group, support group that they had on ground to get across to them. The state of the facilities being used to access care for the NTDs are also fairly poor. The living conditions and the economic power were also poor. Significant low knowledge of mental health conditions, about the causes, about the symptoms, about how to manage it, or even where locations, facilities for treatment are located. One good thing about the group is the fact that they were ready to accept and to access mental health care. How did we go about it? We developed protocols and we tuned the methodology. Ethical approval were received from University of Jos and Benue State University Teaching Hospital. We engaged the policymakers and the gatekeepers in the community. We identify people affected, and then we engage their representatives. Peter was one of them who we were able to use to get across to people around. In fact, I need to always commend him, because using his personal resources, using his bike to go into the hinterland to inform them, and even to personally bring some of them even for assessment. We had focus group discussions to understand priorities of service users, and key informant interviews were also done. And the theory of change was done to know how to really adapt the manual to the local context, and then so that the local actors can be well engaged. We had regular meetings to review progress and address challenges. Quantitative study of the prevalence of anxiety disorder using GAD-7, depressive disorder using PHQ-9 in the affected people with leprosy and lymphatic filariasis. And we used the Open Data Kit software, which was able to, as soon as such informations were uploaded rather, we were able to get them real time. Community attitude towards mentally ill, that questionnaire was used to assess social stigma in the community. Qualitative exploration of service users, carers, and delivery staff were done using the FGDs. Key informant interview for the healthcare leaders to assess feasibility and acceptability of delivery for this pilot work. The effort still continues. We were able to train research assistants. They were brought to Makodi, and then we trained them using the image gap 1 so that they will know how, or the symptoms, and then what to do. The mild to moderate, which they can manage, and then the referral pathways were also taught. Theory of change was carried out. Training of healthcare workers using image gap, as I said. Quantitative study and the focus group discussion were carried out. And then we had to do some mop-ups because, as I said, quite a number of them had gone home and they left the centers, and we had to find a way of getting them to the centers. So reasonable accommodation of all the caregivers were also engendered in what we did. And then we did well gender balancing, which case when we did the focus group discussion, we were able to do equal number of male and female and those who, and is even disaggregated by the disease condition also. Of course, we went ahead with the manuscript writing and publications, and happy to inform us that there are 4 publications were done, 2 already in circulation, and then the other 2 now has recently been published by International Health. Continuous engagement of the civil society continued, and their representative organization. We also presented our findings at different NTD fora. What were the outcomes, the findings? The prevalence of depression was found to be 60.3% in NTD groups, and whereas in the control, we have about 31.2, or twice the control group. Among those with depression, severity of NTDs was similarly distributed, mainly mild and moderate levels. Anxiety disorder was present in 48.9% of those with NTDs of interest, but only in 29.1% of the control group. Well-being was much poorer in participants affected by NTDs, and when compared with the control population. Depression was predicted by the presence of lymphatic filariasis, with the odds being about 9.5 times what is found in the control group. This was after we've been able to adjust for age, level of the education, employment status, family history of mental illness, and even the well-being. And similar findings were found for those with leprosy. We compare what we have before and after the intervention. If you look at these, well, I need to quickly mention that the time interval for the intervention was quite short. We had barely a month, and it's believed that if we had been given, if we had had longer period, close to 3 months, 6 months, we probably would have had significant differences in this. But even with this, we will know that the deeper color was what happened before that intervention, and then this lighter one talks about what happens after the intervention. Significant change was found in social restrictiveness using the common instruments. And of course, looking at the overall common, we found that there is a small change. And as I said, the time interval made all the difference. If we had had longer period or longer time, it would have been, the difference would have been clearer and more than what we have done. COVID-19 was a major challenge around the period, and then affected lightly some of the activities that were carried out. We observed the protocols for COVID, and then, as I said, non-availability of participants was a major drawback because they had actually relocated to their different homes. So, in conclusion, we will say that people affected with the neglected diseases need more than the physical care that we are rendering presently. Their well-being, their mental health will need to be given priority attention in addition to the physical or economic intervention that is being carried out. Their psychological and emotional needs impart on their recovery and then requires attention. Access to care are impeded by many factors. The number of practitioners, the distribution of the practitioners, the location of the facilities are all areas that will need to be addressed. Stigma, discrimination were also identified as hindrances to them accessing care. Integrating mental health services into their care is very important. Effort has been made and is still being made to integrate mental health into, of course, Dr. Afolayan rather, and Dr. Ojo had mentioned all the various interventions and then efforts that are being carried out presently. I would say giants that has been made, ANESVAD and Christian Blind Mission organizing a project presently, which is ongoing, which is also meant to build on what had been done. The same thing we're looking at Imagine project, which we are hoping will receive final nod in the soonest. So many thanks to Federal Ministry of Health, Department of Public Health, mental health program, particularly the coordinators of mental health programs and the NTDs, all collaborating partners and people affected with mental health conditions. So these are my references, and I'm really appreciative of this opportunity. I say thank you to everyone.
Thank you so much, Professor Bindo, for that beautiful presentations. We've all seen from the study being done, and if you have a comment, question, like I said, put it on a chat box. I'm tracking them, and we'll definitely address them later. So we'll proceed to also gain experience, and this is from a friend, a sister partner, that Amasin from Liberia. So we would like to hear about Liberia experience. Liberia seems to have implemented, or they've been implementing this integrated approach for both mental health and NTD, and it's a singular honor to invite Emerson Rogers, the National Case Management Coordinator, Ministry of Health, Liberia, to share their experience implementing mental health and NTD together. Rogers, if you can hear me, you have the floor, please go ahead.
Thank you very much, Lion. Can you please share my screen?
Yeah, just a moment.
Gabriel, are you hearing me, please?
Yeah, I'm on. Yes, you're live now. Go ahead. Rogers.
Okay, hello to everyone. Good morning, good afternoon, and good evening. My name is Emerson Rogers, and I serve as the National Coordinator for Case Management, NTDs, Liberia. Next slide. Obliged to be part of this experience from Liberia. We have a very great impact. Background, we have experienced 14 years of civil war, which greatly devastated the country, but thank God that we are recovering gradually. And interestingly, Liberia happens to be one of the first countries globally to provide integrated case management for people affected by neglected tropical diseases. And the integrated approach was launched in 2016 at the Mana River Union meeting held in Monrovia, Liberia. The integrated approach during that time emphasized on case detection through community health workers, clinical diagnosis and management at health facility level. During that time, we were able to develop a comprehensive training manual that we use to train health workers on case detection, referral, and clinical diagnosis and management. And at which point, we were not providing mental health services for people affected by NTDs. And like you can see, the map there reflects the red point reflects the country Liberia. And case management, NTDs conditions that we are responding to are in the far left, and those include leprosy, lymphedema, hydrocele, Buruli ulcer, onchocerciasis, and yours. Next slide. Now, Redress currently is conducting an action research study in Liberia about integrating mental health into care for people affected by NTDs. And that we are right now compiling, finding the research to realize that it is feasible and implementation of integrated approach of the master plan, the 5 years master plan, current plan. And so mental health integration ideas developed through Redress were considered during the master plan development. And as a national program, seeing the need to integrate mental health with NTDs, we thought it wise to involve representative or the entire NTD unit to be part of the entire developmental process of the master plan. And the master plan is for 2023 to 2027. During the entire processes, the mental health division of the Ministry of Health took part in all planning meetings, even including breakout sections. We ensure that the mental health units of the Ministry of Health made relevant inputs, and their inputs were also incorporated within the master plan. Mental health also was captured within outcomes, activities, within, next slide. Next slide, please. Thank you. Now, the master plan had 4 strategic areas with a lot of priorities. And strategic priority 2 within the master plan has the intensified cross-cutting approaches. And the outcome of that strategic priority, which has to do with outcome 2.1, consists of the integration of identified NTD interventions, including mental health, WASH, and One Health strengthening. And the activities for that includes NTDs diagnostic and management with mental health conditions integrated for a holistic approach. From our experience with the routine integrated approach, we realized that we were not holistically approaching the NTD patients. And therefore, with the Redress research study, we came to realize that with the inclusion of mental health with NTDs, we would definitely be integrating or approaching our patients holistically. And the activities that continue within the master plan that has to do with mental health is update the integrated case management NTDs reporting and recording tools to include mental health. And then we also printed and distributed these integrated NTDs and mental health training manual. what are the performance indicators that we've captured within the master plan? The current master plan has proportion of new case management entities managed for mental health conditions and number of health facilities with at least one staff trained on integrated NTDs and mental health care, case management. Now, this is the intervention pyramid for integrating NTDs and mental health within the liberal NTDs master plan. We see this pyramid usually is demonstrated from the base to the top. So, population-wide initiative, next. Now, at this level, we were able to sensitize the community health workers to understand causes of NTDs and stigma awareness. And we believe that being that the population at this level is very huge and a wider population, so we the sensitization is not only based on case identification of NTDs, but also, creating awareness against stigma and discrimination. Now, we also provided health workers training on basic psychosocial support, and that also includes providing the basic psychosocial support for community health workers and that of health workers. So what of including the mental health into the NTDs master plan is to also provide, including the basic psychosocial use. Sorry for that, as internet connectivity. So we've come to realize that as long as we've trained the community, we train the health workers in basic psychosocial support, okay, provision for people affected by NTDs, and also among the health workers we've identified, we call them second screeners, as to train those second screeners in MHGAP. And we've come to realize that stigma plays a very key role, which the various speakers have dealt with, significantly. And we know that stigma is responding to one's condition negatively. And there are several forms of stigma. You have external stigma, and you also have, self-stigma. But then, how do we manage? How do we handle people, that are stigmatized, or how do we stigmatize people? There are several ways that we stigmatize people, that have these NTDs conditions. But when these people are stigmatized, how do we, okay, as health workers respond to these people? And this is one of the missing pieces that we have been having in the provision of NTDs care services to people affected by NTDs. And we are fully aware that this is the reason why you see it is being captured within the WHO roadmap for 2030. And this is very key because from our experience, we've integrated mental health, with NTDs, and we've conducted health workers training. We've provided basic psychosocial support training to these health workers, and we've also provided MHGAP training to these health workers. Now, based on the decentralization of care for people affected by NTDs, including mental health, we've also integrated within the NTDs care package, the PHQ-9 and the GAD-7. We are aware that these are tools that are used during the assessment to be able to identify whether the patient presenting before you is presenting with some mental instability. And this is a tool that we've incorporated within the integration training manual. We've also developed the all condition clinical algorithm. This is a referral or diagnostic pathway that greatly aids the health workers in differentiating NTDs conditions from other conditions that look like NTDs. So with the use of this all condition algorithm, it helps to reduce the stress of the health workers at the health facility in differentiating at the moment. So the arrow will direct these health workers as to what to suspect and what to consider as not being, an NTDs condition. So we've asked them to post this particular all condition algorithm on the walls of the health facility, especially in the screening room, where they can easily use it as references whenever they are a little bit confused about differentiating which condition. Next slide. During the integration process, as I said, we've captured indicators of mental health within the master plan. And we've also captured that with ledger. So as you can see on the screen, right after the medical history of the patient, those indicators that need to be captured, you will also find the mental health indicator there. That is, that has to do with PHQ 9, patient screen for PHQ 9, patient screen as to whether they were provided basic psychosocial support. These are very, very key indicators that we feel, as far as the integration is concerned, will be able to address NTDs patient presenting before you with mental issues, and see how the health workers will be able to refer these patients to the MHR trained, clinicians, and the MHR trained clinicians are also trained in NTDs service provision. Next slide. What are the progress made so far since the integration? Now, we've trained in 3 counties in the country. Last year, we provided training for 343 persons or health workers, 97 community health supervisors, and these community supervise the community health workers. We also, within these 3 counties, using and then from the 3 county health workers in MHR. So these
Sorry about that, a bit of network connectivity, I'm sure.
Having a lot of bad internet connectivity.
Yeah, go ahead. I'm sure we're almost done with this slide. Yeah.
So as I said, health workers that were trained in both the NTDs and the basic psychosocial gap. And then to be able to really have a firm grip of the marriage between NTDs and mental health, we were able to update the HMIS to include mental health indicators as part of NTDs care. And the mental health and community health team took part in the integrated supervision within the 3 counties. Now, the approach that we've been using since we've integrated mental health with NTDs, whenever we are embarking on supervision, we ensure that supervisors or representatives from the community health division and that of the mental health division form part of the NTD's national supervision team, and this is being done so that the other programs will have ownership of the integrated approach. And during this, we've also provided approach to peer support groups, especially people affected by NTDs. And this idea was briefly brought about during the redress study that was conducted. And currently we have persons affected group being established in these 3 counties. And this group is currently enhancing the work of awareness at their level, the NTDs awareness, and also using that means to help to reduce, stigmatization and discrimination, as we have this myth that these people that have these conditions are either, witchcraft as the result of their own doing. So because, to create the awareness and helping to reduce stigmatization. Lesson learned from this is that integrating mental health within case management of NTDs is highly feasible, and it brings a lot of relief to people affected by NTDs, because at the point of assessment of the persons affected by NTDs, the clinician is able to holistically approach the person before them, and then at the same time be able to identify as to whether the person has some mental instability, and to be able to provide, the basic psychosocial support at that point of care. And involvement of key actors for case identification that has to do with traditional and faith healers. We also involve these people during the training and link. Now, what do we mean by the first group of people that persons affected by NTDs usually run to as means of seeking care? So we've integrated them into the entire package so that when these people come to seek care at that facility where they are, they have the ability to link these persons affected with the community health workers. And then the community health worker will also refer these affected persons to the health facility. At the same time, we are not downplaying, we are not discrediting the fact that they are doing marvelous work, and we are not close with the authority to say what they are doing is wrong, but it's that we are creating that link, that coordination between the traditional and faith healers and the NTDs program, so that we will not be missing on persons affected by NTDs that are being treated in some locality that the community health workers are not aware of. So that link and coordination has been established between the traditional healer, the faith healers, the persons affected, and that also of the community health workers. And we've also have the involvement of mental health and community health focal persons with NTD staff during supervision. And this has greatly promoted ownership across the programs. And it shows that it is not only NTD's program that is responsible for catering so persons affected by NTDs and also associated mental health conditions, but also is the ownership of the mental health program and the community health program, because we are aware that these patients are from the community and they are being referred either actively or passively to the health facilities, for assessment and clinical diagnosis. And then we also pay a very huge respect to the peer support groups. And we've provided some opportunity for group members to provide mutual psychosocial support, and which we've come to realize that is yielding good and fruitful results. As I said earlier, that the peer support group or persons affected are also using be able to disabuse the minds of people that have this myth, and to also encourage those that are affected to be health facilities. So from already, I know that I'm having some internet breaking, but I'm almost at the end. This should
Yeah, it's quite been okay. Yeah, you're back.
So this wouldn't have been possible. This would not have been possible of our, able donors, as you are seeing in the slide. Thank you.
Thank you so much, Anderson. And yeah, sorry about the network connectivity. I'm sure we all listen keenly, following your slide to pick out from these words of experience that you've shared with us. I have posted a question relating to your presentation to your platform just on a private, so check and respond so that I can read it on. We're getting to the end of this webinar, and I'd like to take the last presentation from our own Nigeria context. We would like to see some of our partners have really started doing one or two things in order to integrate or implement activity towards mental well-being and anti-stigma. So I'll call on Mr. Pius. Mr. Pius is the head of programs from the Leprosy Mission Nigeria, and is going to share with us how they've been able to, activities, practical things to do towards anti-stigma and peer support for people affected with NTD. Thank you so much. At the end of this presentation, we'll take a question and then we'll wrap it up just to manage our time. Yeah, over to you, Mr. Pius.
All right, good evening. I hope I'm...
Yes.
It's been quite an interesting webinar. All the presentations that have been made are really very insightful. I will just be sharing from an aspect that reflects on dealing with the issues of stigma, and just a quick insight into the experience of how we as an organization were able to so far make some meaningful impact and contribution. So I just have a few slides that will guide or sort of guide this conversation as we go. Okay. All right, just as the background, the that began in 1874. We're actually going to be marking 150 years next year as a global organization. But it was formally incorporated in Nigeria in 2001. We're a member of ILEP. ILEP is an acronym for Anti-Leprosy Organizations. And we actually collaborate with the federal and state ministries of health in the areas of leprosy, NTD, TB, and mental health. We also collaborate with the federal and state ministries of education, agriculture, women affairs, and some other ministries. In terms of our work, we actually, in terms of our leprosy and NTD work, we currently have projects running in 11 states. With regards to TB, we actually have a presence in 19 states for both the private public mix and for the distribution, for the movement of sputum samples. And we also run projects in 21 states with specific focus on disability. And we have mental health interventions running in 4 states. In terms of our programming as an organization, we are focused on aspects of leprosy, NTD, disabilities, dermatology, mental health, gender, research, TB, applications. Cross-cutting in all these are the aspects of livelihood as well. So our work cuts across the CBR matrix. So we are looking at health, education, livelihood, social, and in terms of empowerment as well. Now, just to quickly come into the area of discourse. In terms of the major challenge here, it's that leprosy is classed as a neglected tropical disease, but it is also a human rights issue, and which it has clearly shown that it is actually directly linked to poverty. In fact, for persons who are affected by NTDs, they are often referred to as the poorest of the poor. Now, leprosy, for the purpose of this presentation, does not just affect a person's physical health. It's also associated with stigma and discrimination, which leads to depression. Professor Obindo had actually talked about the impact of leprosy and other entities on their mental well-being. So it also leads to aspects of divorce, isolation, rejection by their family, the society, even rejection by their own social networks, and eventually even the loss of job or their business. So stigma and discrimination actually leads to the violation of their rights, rights to the community, rights to love and have a family, rights to social association and participation, rights to employment, health, and other public services. In fact, even the aspect of right to vote, we also have been able to recently achieve a milestone, a huge milestone on that when before the 2023 elections in February, we had engagements with the Independent National Electoral Commission, where we raised concerns because people affected by leprosy and from leprosy communities, we are not being registered to vote. And as a result of that, we went to advocate, and after a series of engagements, there were major changes within the Electoral Act to become more inclusive. And so for 2023, we had people affected by leprosy who voted, especially for people who do not even have digits of their fingers, because if you will know that for you to get a voter's card, you need to provide fingerprints. So lots of people affected by leprosy who had no fingers, and as a result of that, they were being sort of marginalized. And so part of the advocacy led to the adjustment where they were now also registered using facial recognition. And so in 2023, they were also able to vote. So the aspect of stigma and discrimination, they go hand in hand. And here I just simply say, look, if you see discrimination, it is just simply stigma in action. The United Nations Human Rights Council had developed a set of principles and guidelines, which is meant to ensure the elimination of discrimination against persons affected by leprosy and their family members. That document has clear guidelines and steps that helps to address and curb and reduce issues of stigma. And it's one of the documents that the Leprosy Mission is also working very closely with. Now, in terms of our experience for the Leprosy Mission, we've had opportunity to work with people affected by leprosy for many years. And one of the things that came out very strongly, we realized, is that just addressing their physical health is not enough to to stop stigma and discrimination, because the impact of stigma and discrimination of people affected by leprosy is what reinforces the poverty and untold hardship that they face. So what we do as an organization is to help restore health, which is the physical aspect, but also there is the social aspect as well. So we also help to restore dignity, hope, and independence in terms of being able to do things again for themselves. So our programs are client-centered, which means they are driven by the people we serve, which it's for the purpose of effective and sustainable local ownership as well. So for us, the strategies that we've adopted really can be categorized into these three main points here under the socioeconomic rehabilitation. And this is not just a magic wand. These 3 points here just simply guides a journey that we've had working with people affected by leprosy. One was the aspect of the fact that many years ago, when we began to, as we work with people affected by leprosy, the focus at the time was largely around addressing their health. We find new cases. For those, they are placed into the program where they are, they begin to access their MDT. And for those who probably experience reactions, they are also linked to the referral hospitals where they receive care. Now, there are those who are found late, and as a result of that, they have complications with ulcers. Now, one of the approach is to form the self-care groups. So many of the communities at the time had self-care groups. Some still do. Now, these were individuals who, after leaving the hospital, are expected to continue to ensure that they care for themselves. And that it's also important if they are in a group and are able to encourage and support each other. But having that in place, there was also the huge problem of the stigma they still face and the challenge they still face in meeting in terms of livelihood. And so what simply played out was to now begin to transition these self-care groups to become self-help groups. So as self-help groups, what we now began to do with them was to begin to sort of train them, build their capacity to be able to together, begin to learn things that they can do on their own. And so, because many of these individuals had something to do before they are affected by leprosy. But some of them, because of deformity, because of the ulcers or loss of limbs and things like that, are not able to go back to what they used to do. And so there was that room for them to begin to learn new things. So those are the kind of things that we began to do with them. But one of the key things that played out was point number 2. When we formed these groups, it was much more like an opportunity to sort of have them in a place where you can easily reach them. And therefore, what we were doing at the time was largely trying to meet their basic needs. So we often will come to the group and probably provide food. We come to the group and just provide some basic materials that they require, some of their toiletries and things like that. That was what was the approach at the time, which was the charity or the welfare approach. But we now realize that for them to be able to function as a group, for them to be able to begin to take steps to begin to sort of raise their own livelihood, change their mindset, because a lot of them over the years have now depended more on begging. So for you to move them from that aspect of begging to a more sustainable approach was where we introduced the right-based approach. And the right-based approach here is simply an approach where together with them, we begin to plan and consider aspects of the things that they can do. And then also about contributions they will have to make, and the contributions that we will also have to make to be able to transit them from that charity and welfare approach. There was a huge concern, there was a huge outcry, because as far as they were concerned, they had largely become used to the charity approach, where they just wait for things to be given to them. But we eventually, through a process of teaching, training, capacity building, was able to transit them into the right-based approach. And one other aspect of the right-based approach is also about helping them to understand their rights. So we build their capacity in knowing their rights, and then also in understanding their positions as right holders, vis-a-vis linking them up to duty bearers, building their capacity to advocate for their rights from duty bearers. All these were methods for sustainability. Now, the third point was when we were able to achieve that level across most of the groups, we also now realize that, look, it is important for these groups to also plug into government program opportunities, because most of the government of the states also have programs that is targeted at providing, at meeting, at supporting vulnerable groups. But most of the governments and even some of the development organizations rather prefer to support groups rather than individuals. And so on the basis of that, we now supported them and began to work with them closely to also develop business plans. Eventually, they were registered at their state's ministries of commerce and industry as cooperative groups. As a result of this, they are now able to also access some of the government grants when it is available. So these are some of just the transition that we have, some of these self-care groups to self-help groups, and eventually now we have a lot of them as cooperative groups. Here it's just a picture to show some of them who were trained in tailoring have gone ahead to now open their individual businesses. Some of them have opened group businesses as well. Some had even gone into training, bead making, facial makeup, and they are currently also producing, and we've also linked them to also our networks, to our network outlets, to be able to sell their products. Because one of the huge concerns is not just about being able to produce, but also where to sell. Because of the aspect and challenge of stigma, for example, some of them are into farming of vegetables. Now, many people will not come directly to buy from them. So what we've done was to link them to those who are into marketing of vegetables. So they become like middlemen who will come to buy from them and then sell to the main market. We have this group in Zamfara that went into animal fattening. So what they do is they buy, calves and buy sheep and goats, and then they fatten them, targeting festive period, and then they're able to sell and then plunge that money back. And there's a portion of it that goes into the hands of the members. So in terms of some of the challenges that we actually faced working with these people, there's the aspect of stigma and discrimination. It goes beyond, how people see them. It gets to the point where they also begin to self-stigmatize. And for many of them, to even come into a self-help groups was even a huge challenge to overcoming that prejudice. The other challenge we found working with the self-help groups and eventually becoming cooperative group is lack of trust. Some of them, to build trust among group members, we found that it was difficult because of past experiences of isolation and discrimination that they've experienced. And a lot of them is also about apprehension of how they are able to raise resources. And of course, there is the challenge of limited resources. And then there is also the challenge of health issues, because some of them still have health complications that as a result of either ulcers that keep recurring. And so some of them are not able to engage in income generating activities, and which is also a significant barrier. And then the aspect of education and their literacy level, the low level of education and literacy among most of the group members is also impeding on their ability to how to probably do simple bookkeeping, keep records, and how to access information that is necessary for the group development. Another aspect is that of group dynamics. One of the things we did was to try to see if other family members or other people with disabilities in the community can also join those groups. So which some groups have opened up to, but maintaining that group cohesion has led to a lot of conflicts, and the challenge of how to resolve that was also something that we had to, at the time we had to take them through a training on conflict resolution. And then the other challenge is market access. So finding markets to sell their products, like I mentioned earlier, was also a significant challenge. Many of these groups, they lack the connections or research or information and all that. Then the aspect of sustainability was also a problem. So ensuring the long-term sustainability of self-help groups as they transition into cooperative entities was quite difficult, especially if there is not ongoing support to help them to sustain. Just quickly, as I begin to round up, some of the lessons we've learned here is that the community-centered approach, when you get the community involved and they take ownership, it's very essential. So empowering persons affected by leprosy to take the lead in forming and managing their self-help groups ensures actually the sustainability of those groups. And we've also seen the aspect of training and capacity building, that by providing training and capacity building programs, you find that members were able to develop, to run their groups and their cooperative setups. We've also seen that the tailored support in recognizing the unique challenges and the needs of people affected by leprosy has also led to more effective self-help groups and cooperatives. And then we've also linked them up to access to microfinance, to the Bank of Industry, and to some other groups. I know it's just for time, so I would like to say thank you here for your kind attention. I'm open to any questions, because I've had to just try to collapse a lot within just this short time. So thank you. Hand over back to you, Gabriel.
All right. Thank you so much. And honestly, we've seen how people affected with NTD are being supported, most especially livelihood activity. It's been quite an exciting presentations from one to the other, and we're so grateful to all our speakers for doing justice to the subject matter. I decided to leave the question to the later part of this webinar so that we can manage our time very well. And I'm also aware that some of us have dropped a question on the Q&A section, and some of them have been answered directly. So we've come to the end of this webinar, and would like to just take like 10 minutes to entertain questions. So if you have questions that are yet to be answered, please, this is the best time to bring it up across. It can be directed to any of the speakers, which we'll be glad to do justice to. So let me read out one from Yusuf. So Yusuf is asking, how can the issue of resource allocation among members of self-help group be addressed? How can the issue of resource mobilization, resource allocation among members of self-help group can be addressed? I think this is directed to the last speaker. And also you have educated the leprosy group about their rights. But what steps have you made in educating the populace about the rights of this group? So this education should be both ways. The leprosy group have been educated about their rights. There's a question from SCN, how or what steps have you made in educating the populace about the rights of this group? And then another one from SN, it says, regarding helping the leprosy group create a market for their product, how will you help those who sew clothes? So, I mean, this person is asking for practical way in case the means of livelihood of the affected person is making beautiful dress. So how can you help them also market their product? I think Mr. Pius can answer these three questions quickly, and then we'll take others and we can wrap up this webinar earlier than planned, at least in the next 10 minutes. Yeah, thank you. Over to you, Mr. Pius.
Okay, thank you very much. And thanks for this very insightful questions. With regards to the first question, which talks about the aspect of, I think his aspect is, it talks about issue of funding, right? How to, is it in terms of how we can support them to access funds? Because I missed that one. It was the last two I got.
Yes, how can the issue of resource allocation among members of self-help group be addressed? How do you ensure fairness? Yeah.
Okay. Oh, thank you very much. Now, I will use one group as an example just to give clarity. For example, the group in Zamfara that went into, because what we did, we have about 7 self-help groups in Zamfara, 7 self-help female groups in Zamfara. Now, each of these groups have picked on specific areas, and depending on, most of these groups are formed based on where they are located, because we found that it is easier if they are located or living around the same geographical area. And so for one of these groups, for example, they are into animal fattening. Another group is into aspects of production of throw pillows and bed sheets. Another one is into the production of beads. They do all these beads work, necklace, earrings, and the rest. Now, take example of the one that rare animals. Now, when in those groups, you have some of their members who are advanced in age, and so really are not able to practically really run any of those businesses, but they are members of the group. You also have individuals in the group who want to do their own business. They want to run their own individual small business by the side, which is what we also encourage. Now, when they fatten the animals, during festive period, they sell the cattle, and then once they sell, the money that they gain from that is broken into 3 parts. The first part is recouping back the investment amount. So what they do, they take that back and then they plunge it back and buy other animals which they begin to rear. In that amount is also the aspect of engaging with the getting the animals vaccinated. So that one is there. That's the first part of the money. The second part of the money is what they keep for members to be able to borrow from. So members are able to access those funds as a grant, which they pay back really without interest as members. But they also keep that money to encourage other members of the community who are not members of the group, who want to loan money. They are also able to come to loan, but they loan them at an interest. So that's the second one. So for members of the group, they can borrow, do their business, but they also pay back within a particular time frame. The third portion of that money, they keep as emergency or as welfare for themselves. So it's out of that kind of money, they support the aged ones among them. Besides the fact that as a community, they normally just, if they cook food or things like that, they normally will support those ones, but they also take from that kind of money to support. And I've also seen them where if they have members who put to bed and they go and buy things for them, or somebody whose child is probably getting married, they support from that kind. That's what they do. So for those groups, that's how they're able to manage their money, which we don't really interfere with that. So we talked about, we've been able to raise awareness amongst the people, build their capacity, and all that. What happens to the populace? Raising awareness amongst the populace is an ongoing intervention. But what we've done largely as an approach, in the communities where we work, we do not just walk into the community and work directly with people affected by leprosy alone. What we do is we carry the established authorities in place. Either at the state level, we are working closely with Ministry of Women Affairs that has the mandate for social works. For every intervention we do, even for the self-help groups, they are fully involved. And then we've also conducted training for the staffs of the Ministry of Women Affairs to understand the issues of leprosy and to demystify the myths and misconceptions. Then working with also the religious leaders in the community and the traditional rulers. So we work very closely with them. We've had sessions with them. We've built their capacity in terms of the aspect of understanding leprosy and all that. And so, and as a result of that, I can give you one example. If you go to Gusau today, in the council of the Emir of Gusau, one of the people there as his council members is a person affected by leprosy, who was actually turbaned and recognized as the head of people affected by leprosy in Zamfara State. So that's how closely we've been able to build that network with them. Then we also have linked them up with Jonapid. Before now, people affected by leprosy, we are discriminated against by even Jonapid members. But through that engagement and interaction and our programming that is now looking at inclusion, you will now find that self-help groups today in the community is not only for people affected by leprosy, but people with disability. And people affected by leprosy is now a block in Jonapid. So if you check the list of blocks in Jonapid, you see IDEA as a block, which is the platform for people affected by leprosy. So we've also trained and engaged with media practitioners in the state, both print and electronic, to be able to understand the issue of leprosy, the use of the right terminologies, because largely labeling is one of the things that sort of entrenches issues of stigma and discrimination, so that the media people will use the right terminologies, and we've used the platform of radio and TV on a regular basis to discuss and raise awareness. So that's one of the things that we've done. And then the last question talks about for people who go into clothes making and other things like that, how do we ensure that the populace or people, they get access to the right market? I can say to you very clearly, I just had the opportunity of coming back just the last few days from a trip to one of our TLM countries in Australia. Those who produce beads here in Nigeria, those communities are already supplying our TLM Australia. They have a unit for trading. So they are already supplying them these beads. All we've made sure is to be up to international standard. So as I speak to you, they've had their first supply and they've been paid. And I just came back from that trip, and they're already saying, they're already giving options of the kind of product that they want, and are already asking if they can produce it. And we can also get stories from these young people. They are able to promote and sell it, and they'll put it in their catalog. Now, there are those who are one of the women groups in Zamfara producing trophy. You will not know except you are told. Well packaged and all that. And we are helping to link them up with marketers in Gusau Town. And some of us are also being able to buy those same products, and we are able them to sell in our other states. Those are some of the things we're doing. Whatever involved in standard, because what people are looking for is quality, as much as possible. Thank you.
Thank you so much. I think we've addressed all the questions, both in the chat box and then from everyone. I don't know if there's still anyone with any question yet unattended to. If justice has been done, I want to sincerely appreciate everyone for your time on this call, and to also appreciate the consortium for global health for putting up this webinar series as one of the activities to mark the Global Health Week. We from the Federal Ministry of Health were happy and glad about this collaboration. And we do hope that this webinar, in a way, has added to your knowledge and your technical know-how. The goal is very simple. We have to scale. We have to scale the implementation of mental health, integration of mental health and NTD program in order to ensure primarily the goal that we have set for ourselves in the NTD master plan, and to bring public good in the spirit of universal health coverage to the people affected with this comorbidity. At this point, I sincerely want to appreciate everyone, and it is from this point that we'll draw the curtain from this webinar. Thank you, everyone, and hopefully we will come your way some other time. Thank you, everyone, and thank you to all our speakers. We really appreciate everyone, and see you next time. Yeah, thank you.